Okay. Let's see if we just give them some time to log on. I'll just wait 1 more minute before I start.
No problem. Yeah.
Okay, so let's start with the introduction. Welcome to the next session of Global Health Week 2020. And this overall theme this year is global public health. And we had 2 lectures last week, and there will be 2 more this week. So make sure to look into the overall Facebook event for more information about these lectures. And we will have it also in a slide later on in the session. And today we're going to speak about global trade and public health, perhaps an unknown topic for many of us, and at least for myself, and not often discussed in the field of public health. But first, I'm going to discuss or inform you a bit more about the organization behind this event. And then I'll introduce you, Miguel, our speaker tonight, Miguel San Sebastian. So we are the Swedish Society of Medicine's student and junior doctor section. In Swedish, the short for this is SLS KUF. It's quite a long name, as you see, so therefore the short version. We have programs on both local and national level with organizations in, for example, Örebro, Linköping, Stockholm, Uppsala, etc. And our focus is to empower and spreading knowledge. If there are topics that we find that we would like to know more about, if it's not enough in our education, then we try to, through workshops or lectures, to make sure to have experts ready to bring us this more knowledge or research or whatever it might be. This is in ethics, it's in more social sciences, and in medicine in general. We also have work focusing on society and education, writing articles and trying to take a stand in questions that affect us as young doctors or medical students. And we also have awards and grants for specific matters, for example, in research, but also for those who take a stand in the debates of society. So if you're interested in this, you can become a member if you study medicine in Sweden or if you are a junior doctor. And you can find out more on our website. But from this, let's go to our speaker today. Now we have a photo here, but we have you live also, Miguel. But I just wanted to make a short introduction. You are, if I understand it correctly, medical doctor with a MSc degree in control and infectious diseases, as well as a PhD degree in environmental epidemiology from the London School of Hygiene and Tropical Medicine. But myself, I and many students with me, we know you as a professor here at the Department of Epidemiology in Umeå, where you have courses both for master students and PhD students. And today we're going to get to know a bit more about the connection between global trade and public health. So I would like to give the word to you now, and I'll stop sharing. Let's see if I can do this there so that you can share your slides. I hope this works.
So I'm now sharing.
Let's see. Not yet on my side.
Oh, because okay, I have to share. Yeah, now, because I was sharing before, but now, yeah. Right.
I think now, yes, perfect. Now we can see your screen. Thank you.
And you see all the screen, or just everything, or just the slide?
We see the whole PowerPoint background.
Okay.
Not just the slide.
Okay. So now.
Perfect.
Okay, then. Thank you. Thank you very much for the invitation. As Hannah said, my name is Miguel San Sebastián, and then I'm going to present this topic about the connections, try to disentangle a bit the connections between trade and global trade and public health. And she didn't mention that I live for a long time in Ecuador, and I think my interest to this topic came from my relationship with the farmers and indigenous people there, and how the prices of coffee when they were going to sell change every day, and therefore it somehow intrigued me. I mean, what are the connections? Why this? And then when you go into go a bit deeper into that, then you realize that the prices are based on offer and demand, but decided somewhere else, and by multinational companies, or by a particular company based in a usually in a high-income country. The picture that shows in the first slide is a meeting on the left side hand of the World Trade Organization, where the ministries of trade gather every 2 years, more or less, and then where they take decisions on our behalf as citizens to certain issues. And on the right hand is the people outside that meeting and protesting and claiming for a better world, and a world where trade is made for everybody. And I think these two slides illustrate the whole presentation I'm going to do, this tension that exists between a series of powerful people making decisions on behalf of the farmers and the citizens of our societies. I'm going to first start with to frame trade, because Hannah asked me that, to frame trade as a social determinant for health. Then I will introduce briefly how the World Trade Organization works in order to understand the implications and the agenda that they have. And then I will go through 5 key trade agreements, and just very briefly, but with simplifying the implications of those agreements for public health. And finally, well, it's a kind of summary about what are the current discussions and if we can do something, and then maybe open it to discussion with all of you. Okay, let's start. Maybe you have seen this, I think, the previous week. I mean, in the sense that there is a series of social inequalities in health, and this can be expressed between socioeconomic differences in health between different countries, like this slide, where you can see that between rich countries and poor countries, there is a gap in life expectancy of 30 or 35 years. But these kind of socioeconomic differences are not only between countries, but there is as well within countries. And this, for instance, a slide shows the gap in life expectancy, trends in life expectancy, and the gap between high and low educated here in Sweden, and how over the last 20 years, even if life expectancy has been improving in all the educational strata, the gap between the high educated and the low educated has increased. All these differences, or socioeconomic differences in health, the way we explain these differences is because we think that they are produced by social determinants of health. And based on a work that 2 researchers, Dahlgren and Margaret Whitehead, they did some years ago, the WHO took this as a kind of generic framework in order to explain why the socioeconomic inequalities in health are produced and reproduced over time. And here you can see that there is a core, maybe I don't know, Margareta, maybe they went through this last day. I'm not sure. But then there is this core of genetic factors, which are influenced by individual lifestyle factors, which are influenced by more broader social and community networks, which are influenced by certain policies, the history and policies regarding employment, education, or healthcare, or food production, and so on. So are these major socio determinants which are going to influence and going to determine who is going to be healthy and who is not. When we talk about globalization or global issues, there are different frameworks as well, based on the previous one that I meant. I pick up one of them, which has developed by Huinen from Holland, and where they explain globalization, or they understand globalization and intensification of a series of processes, political, social, and cultural, that lead to a series of international and global structures. And these structures can be divided in four main. One is this global governance, the other one is the global markets, the other one is the global communication, and global environmental change. And these four obviously interlinked global forces are going to determine, are going to influence how health is distributed in the society. The topic I'm going to talk today is focused on this global governance and global markets. And this is going to lead on how different powerful actors at the global level implement a series of policies that are going to have consequences for the health of the citizens. At the end of the 90s, the World Health Organization, in a document in the World Health Report, stated that in this century that we are now living, the interrelationship between global trade and industrialization and environmental sustainability are going to be the major public policy issues, because they are going to have enormous implications for health and for public health. There are plenty of free or trade agreements, like for instance, the European Union is one of them, NAFTA between Canada, US, and Mexico, and a series of agreements, and another kind of agreements between within regions and between regions. But I'm going to just focus on the World Trade Organization, because the World Trade Organization is the mother of all these agreements, and none of these, all these agreements can go farther than World Trade Organization. But the core of all these, of the different specificities of the agreements, are based on the World Trade Organization. The World Trade Organization originated in an agreement that was called GATT, General Agreement on Tariffs and Trade, that was developed after the Second World War. And the idea of this agreement was, on one hand, to be able to build the societies that had been destroyed during the war, and in order to create a more stable international market. Over the years, this kind of thinking was, or core thinking was, or lost its strength, its essence, and then the World Trade Organization, or the GATT, evolved into by pressure from the multinational companies. They wanted to liberalize more and to somehow eliminate those protections into some kind of more infrastructure called the World Trade Organization. So instead of being a series of meetings that the ministers of health are in different countries, it became a building based in Geneva. And the difference between one of the two main differences between the World Trade Organization and the previous series of trade rounds is that before, it was the General Trade Agreement on Tariffs and Trade was related to goods, but then the World Trade Organization became covering most of the things that we can think about trade. So it's goods, but it's agriculture, it's services, it's intellectual property. And the other big difference is that the World Trade Organization has created a court where countries or multinational companies can sue different countries. And the outcome of these trials is compulsory for the countries. So this is the only state, like the only, I would say, the only institution in the world that has this capacity or this strength of making that countries fulfill what this court decides. So it's a court with an enormous power, and as I said, and with the examples that I will put later, you will see how different multinational companies can sue different countries, violating to some extent the sovereignty of these countries to make decisions. Right now, the World Trade Organization has 164 members countries, and the decisions taken in the World Trade Organization are by consensus, and there is a ministerial conference that is gathered every 2 years. So since they started in the 90s, every 2 years, more or less, there had been a meeting. There is a general council as well that gathers every month, and then they see these day-to-day operations, but as well to direct if there is the case for this dispute settlement system. In the World Trade Organization, they work around 600 employees. And just to give you an idea of the difference in terms of the level of the negotiations, I would say that, for instance, US has 250 persons that they are there for lobbying for the multinational companies of their country, while there are many low-income countries that they don't have any person there. So this is the kind of the play, the field play that they have at that level. The aim of the World Trade Organization, according to their statutes, is that human welfare is to achieve human welfare through economic growth based on trade liberalization in the context of non-discriminatory and transparency. And for them, for the World Trade Organization, trade liberalization means, on one hand, the regulation of the state. On the other hand, is to eliminate any barriers for trade. We'll show you later with some examples the contradictions that they have been operating and the consequences or implications that this has for health. The basic idea is that if we don't have barriers for trade, the trade will increase. This will increase economic growth, increase wealth, decrease poverty, and increase health. And therefore, if we have a healthy population, there will be an increase in economic growth, and the circle will somehow continue. So this is the basic idea of how the trade, according to the World Trade Organization, could influence and benefit the health of the populations. So the World Trade Organization, in order to facilitate this free flow of trade, is organized in a series of multilateral trade agreements. I'm going to put an example of 5, and very brief. I'm going to describe them and put you an example relation to health. But there are more than these 5, but these 5 are classical ones because the huge implications that they have for health. Yeah, forgot that just to understand a little bit more how the World Trade Organization works. The World Trade Organization has 2 main clauses, and these are related to this issue of non-discrimination that I mentioned before. One is the called most favored nation clause, and the other one is national treatment clause. The most favored nation clause says that countries cannot discriminate between each other. And as an example, in relation to trade. An example, for instance, that happened a few years ago is like with Holland wanted to favor one of his ex-colonies in the Caribbean with the import of bananas. But then Spain said that is an exporter of bananas said, no, you cannot do that, because if not, we are treated unequally compared to that particular island. And therefore, the Dutch government could not do that negotiation, what a special treatment with that particular country. So it's like, between the countries, they challenge each other in terms of this equality, which is in reality is not equality because we are not equal countries. The second one is this national treatment clause. The national treatment clause refers to products, and this basically says that products cannot be or countries cannot benefit specific products from those countries. In that way, that for instance, if Sweden would like to promote a particular product of the country, like I don't know, beer, for instance, or a car, can easily come a multinational company from US or from another country and say, no, you cannot give benefits, or if you give benefits to your particular national product, you have to give the same benefits to me. yes, but we want to, I mean, this product is becoming now new in the market, so it needs some kind of favor situation and so on. So, but according to the rules of the World Trade Organization, this cannot be done. And if countries continue with that, then is where this trade dispute court enters into action. And I will try to illustrate again how the implications that this has for the public health or for the health of the populations. This is basically what the WHO says about health, and basically says that every country can have any measures to protect the health of their population, except when those regulations, well, with those regulations in public health, we will call them policies, when those policies do create an unnecessary obstacle to trade. So governments can do and can apply and can implement any policy or strategy regarding the protection of the public health of their citizens, except when that policy create a barrier to trade. And I'm going to move now into these 5 different multilateral trade agreements, just to see or to give you an idea, hint of the implications for public health. So these are the 5 ones that I'm going to mention. The names that don't matter so much, but just you are able to keep the example or to understand the example. I think that's enough. But the first one will be technical barriers to trade, which is related to products. The second one is sanitary or phytosanitary, which is more related to food. The third one is TRIPS, this trade related intellectual property, so it's related to inventions. And the fourth one is related to services, any kind of service. And the fifth one is related to agriculture. So these are different that you could imagine as well. Are all of them can be connected to different aspects of health too. Let's start with the first one. So the agreement on technical barriers to trade refers to eliminate all. So the whole idea of all these agreements is to eliminate any barrier to trade. So in the sense that there is no tariff, there is so the products can move from one country to another freely based on the offer and demand. So this agreement covers all goods. I'm going to put 2 examples to illustrate the dimensions of this agreement. One is a dispute that was between Japan and the European Union and US regarding car emissions. And Japan introduced a new model, wanted to introduce a new car model into the market in order to fulfill the Kyoto Protocol. So in order to reduce the CO2 emissions. So they entered into their own market a car that was going to reduce the CO2 emissions. But the cars that at that time had the European Union or US were emitting more, and then the Japanese, and then they complained that the Japanese was benefiting their own car companies. And because of this, Japan had to change the environmental norms and allow as well in their own market cars that could emit more CO2 to the environment. Obviously, this has consequences for the health of the citizens, but as well for climate change and subsequently for the health of the populations. In the 90s, the Thai government decided to ban the imports of tobacco from outside the country. It's true that Thailand has some kind of tobacco production, but it was relatively small. But they say in order to limit, or in order to decrease the tobacco smoking in our country, we are going to ban the selling of tobacco by multinational companies. Then the tobacco companies, mostly from US, threatened the government to put it in this court, WTO court, if they don't change the norm, if they are not allowed to sell their cigarettes. And because they were feared, the Thai government was feared that this could go to, they could lose in the court. So they allow again the tobacco companies to enter into the country and sell more tobacco. So these are kind of public health policies that the governments could implement, but because of the threat of multinational companies or other governments representing multinational companies, the governments are forced to change their public health regulations. The second example relates to mostly to food safety. And in this agreement is very specific, or is a bit different from the previous one, in the sense that in order to say that something might harm the health, they have to show scientific evidence. And you might know that sometimes this is not so crystal clear, and that there is the scientific evidence somehow is not so strong, and you require certain studies to show that. So it's not so easy to really produce scientific evidence. So in the 90s, the European Union decided to ban the import of beef that had been treated with hormones in the US. And the argument of the European Union was that, okay, first, that there are some studies showing that might produce some neurological, maybe in cancer. And in order to protect the population, they decided to do this ban. The US went to a court, and the European Union lost. And the European Union, or we as citizens of the European Union, have been paying every year $150 million to US for protecting the health of the population. So imagine this kind of contradiction. So the European Union tried to protect the health of the population, and the US put the European Union in court. They lost, and then the European Union has to pay this fine in order to protect possible consequences of eating beef has been treated with hormones. The case was solved in 2012, and the agreement was that, okay, the European Union is not going to pay anymore to US, but we will buy much more beef, non-hormones beef from US. So this was the kind of agreement that both, let's say, countries achieve. But again, imagine the consequences and implications for when they are US or multinational companies are negotiating with low or middle income countries too. I mean, the European Union could pay this kind of fine, but obviously many other countries will not, and therefore they don't go to court. So yeah, at the end of the day, they just follow what they have to change their own regulations. The third one is the so-called TRIPS, this trade-related aspect of intellectual property rights. This is a very broad and complicated agreement because it relates to anything that is related to these property rights and patents and copyrights and so on. And among them, definitely are everything related to medicines, because they go through this process of property rights and patents. But it's not only related to the issue of drugs or medicines that is somehow mostly related to health, because here there is a lot of traditional knowledge which can be patented, or life forms and genetic consequences. And many of these already companies are patenting without the governments knowing, without people knowing, and without not knowing very clear the potential consequences that this might have for the future. Basically, the TRIPS, what says is that, okay, if once some drug, for instance, I will focus on the issue of drugs, one medicine is registered, the multinational company or the pharmaceutical company should have 20 years of patent protections in order to recover the cost that they did during that time. Thing is that during these 20 years of protection, I mean, this becomes a kind of monopoly, and nobody can produce the same drug, even if they can. And so therefore, they have a control of the market, and then they can use they can manipulate the prices as they want, and therefore increase costs and decrease patients' obviously access to those drugs. Most of the time, developing countries or low-income countries be excluded from the benefits, because 7% of all are or belong to owners in high-income countries. There is very little investment as well in new drugs, because like there was a study showing like only in the last 5 years, only 1% of all new inventions or new patents in relation to drugs were related to, for instance, tropical diseases. so which are mostly relevant for low-income countries. So a lot of this expenditure and cost and investment that are relevant. A difference as well, showing that really trips was, I mean, the purpose of one of the purpose of trees was to increase this investment in low-income countries, and this through technology transfer, and this has not happened. Just put the dimensions, the norms, and the South Africa has been one among African countries as well, has been devastated, but in the 90s, HIV, AIDS, and South Africa in the end of the 90s had the possibility to produce antiretroviral drugs by themselves, but they were patented by multinational companies. So what they claim is that they claim, South Africa government claimed that the possibility to get this, what is called this compulsory license. A compulsory license is something is you appeal to it, or you look for them when the country has the capacity to produce that drug, but still is under patent period, and therefore the country or the small company has to pay a certain amount to the other pharmaceutical company in order to allow to produce that particular drug. And that, I mean, that possibility, for instance, in countries like South Africa or Brazil, create or produce that the cost of drugs for each individual person was going to decrease by thousands and thousands of dollars. So the saving that this could produce in order to into the South African or Brazilian market was enormous. And in 2001, pharmaceutical company to the whole government, South African government, and told them, okay, you cannot do that. If you go that, we go to this court, and then you will lose, and then you will have to pay even more. So, and then, well, there was a lot of campaigns in the beginning of 2000, and then at the end, these drug companies withdrew the case. But yes, this is an illustration of how they are behaving commonly, all these multinational companies, in this particular case, pharmaceutical companies, or the possibility that they have in order to sue the governments and to make them pay for something that should be the right to the citizens to have access to these drugs. In 2001, the World Trade Organization decided that this compulsory license could be given to countries that can produce that drug. So this is a limited number of countries that can produce drugs when there was a national public health emergency. And then countries wonder, well, okay, what do you mean by that? And they say, okay, we mean that you can produce drugs only for HIV, malaria, and tuberculosis. Yeah, what about the other diseases? No, you cannot about the other diseases. And that has been a continuous fight within the World Trade Organization. A lot of pressure from NGOs, international NGOs, try to change this this kind of agreement to make them more soften and more accessible for particularly for low and middle income countries. And in 2017 came a new amendment where the compulsory license could be allowed for only these generic medicines, so not only for HIV, malaria, but for a series of medicines, and that they could sell. I mean, countries like South Africa that can produce these generic medicines could sell them that to other low-income countries that don't have that capacity. The big issue now in this kind of agreement is what happened with another kind of drugs, for instance, cancer drugs. And countries like, I don't know, I read that last week there was a dispute between, for instance, Singapore and US. And because Singapore can produce cancer drugs, but they still are under patent, and therefore the US companies don't want to allow to Singapore to be considered one of these compulsory license. So there's a big fight between the different countries about what to do or what not to do, or if I can produce or not can produce certain drugs. So this is the coming fight among countries regarding drugs is not anymore maybe HIV, but is the cancer drugs. There is something, in case you read, but there is something the negotiations within the World Trade Organization regarding TRIPS have been conducted, and therefore they are establishing negotiations between bilateral negotiations between two countries. So US to some extent is forcing different countries or different small regions of the world to go into more TRIPS plus, so even more extension of this protection of the patent. So in order to make even more difficult to countries, to low-income countries, to access the drugs. The fourth agreement is related to services, and services is very broad, and they can go from health, education, telecommunications, electricity, water, sanitation, all these kind of waste management, all we somehow have in our homes and every day, and we need them and we use them, enter under this agreement. This agreement is very different from the others in the sense that, again, these are mostly between bilateral. It's not like the others that can be negotiated in groups. Here is a bilateral. So for instance, Sweden says to Tanzania, okay, I would like you to liberalize your water because my water companies want to take that into the market. So there is this kind of bilateral negotiations that are done. And these negotiations are done without knowing the parliaments, without knowing the citizens about what the different countries are liberalizing. And the problem with this liberalization is that this particular agreement has something that is called lock-in effect. And that once a commitment is made, it's very difficult to say no to that, or I don't want to participate more. And that has enormous implications because one particular government might sign an agreement, but then the next government, which is not in that particular ideology, for instance, or see that this has very bad consequences for the country, then they cannot change it because the consequence of changing that will imply enormous economic penalties. The GATT says that, okay, this covers all services, but not those supplies in the exercise of government authority, but it's not very clear what exactly means that. They say the World Trade Organization says, okay, that is that service that is only supplied when there is no commercial basis or competition, but hardly there is no, in any country in the world exists this purity right now. Like, I mean, if you think about healthcare or or education in the Swedish in the Swedish system, I mean, there are a lot of small, even small or big private actors involved there. So there is on how are the consequences for instance, for education, for the educational service, if Sweden would sign this kind of agreement, are very difficult to imagine. This agreement is very complicated. I'm not going to enter into it. I'll just leave that. But one of the modes is that private providers can, if you sign this agreement, private providers can go to a country and establish a private clinic or private hospital without permission of the government, because according to the agreement, there is no regulation that can, or there should not be discriminations against a private actor. That means that different multinational companies into the healthcare sector could enter in any country that have this agreement and put any hospital wherever they want, because they should not be discriminated in relation to the public sector. Because of these consequences and because they are not so clear, most of the rich countries have not signed this agreement, at least for education and health, because the consequences of this are not very, under the imagination of what could mean this for the population. So most of the signatures of these agreements come, unfortunately, from low and middle income countries. So if you see, for instance, from a report published a few years ago. I mean, these are the total members that have liberalized medical and dental services in 54 countries, and 36 of them belongs to low-income countries. That means that the middle and mostly rich countries don't want to liberalize these kind of services because they don't know the consequences of this liberalization. They don't know what could be the implications, and because of the lock-in effect of this agreement, yeah, that would be to enter into a kind of trap for the governments that signed this agreement. But the implications for low-income countries, there are several reports already talking about the implications that this have in order to diminish the public services, the public health services in relation to the private ones. The final one is this about the agriculture, and this is an interesting agreement because basically the agreement on agriculture of the World Trade Organization is based on their philosophy and ideology that there should be a free distribution or free market for any kind of product, and then the whole agreement is how countries should reduce these subsidies that farmers are given, and on the other hand, the agreement establishes how to reduce the tariffs, so the taxes or the tariffs that the products from abroad are charged within the countries. And I will show you with as an example how continuously rich countries violate this kind of agreement. So even if they say that the market should be liberalized, the rich countries don't want to liberalize. And I will put the example with what is called the Common Agriculture Policy, the European Common Agriculture Policy, which is known as the CAP. But the US Farm Bill, for instance, is similar, or the ones that they have the different kind of agreements that regulate agriculture policies in the different countries works in the same way. The Common Agriculture Policy for the European Union is a kind of is very tricky, and is a kind of headache for the European Union, because it's currently taking 36% of the whole European budget, which means 58 billion per year, to dedicate only to 5% of the workforce. So 5% of the people in Europe is dedicated to the agriculture, but 36% of the budget goes to them, and mostly goes in terms of subsidies. So the whole farming in Europe is subsidized in order to put into the market and distort the market, because the products of the European Union are at very low price in order to compete with products that come from low or middle income countries. Yeah, I will come back later in a moment to this. There has been studies as well about the potential impact of these kind of protection policies, because, for instance, has been a study showing that the European Union pays around 2 million euros every year in order to protect, for instance, the tobacco production. So on one hand, due to this agreement, the European Union is protecting the tobacco producers in Europe. On the other hand, is spending money on public policies in order to prevent people from smoking. So imagine this kind of contradiction. On one hand, we protect tobacco producers. On the other hand, we are spending money on preventing tobacco smoking. Unfortunately, as well, because you can think, okay, at least the farmers are benefiting, but most of these subsidies goes to the rich farmers, so to the largest farmers. So 70% of the money that is under subsidies go to 20% of the largest farms in Europe. And this happens similarly in the US. There are two policies that are the core of these agreements that the rich countries don't want to somehow to leave. One is this about subsidies, and the other one is to tariff barriers. And the subsidies is like, for instance, oranges produced in, we put an example, oranges produced in Europe cost around 10 euros, for instance, because they come from Italy, or from Spain, or from Greece. But Morocco has oranges that can be put at 5 euros. So what the European Union does is to give money to the farmers to put those oranges to less than 5 euros. So in that sense, they are cheaper than the Moroccan ones. Obviously, this is a violation of the idea that they have in the World Trade Organization, because the whole point of the World Trade Organization is to liberalize and to create a kind of a global market where there is no subsidies, there is no tariff barriers, and so on. And the same happened with the tariff barriers. So for instance, an orange from Morocco coming to Europe, to the European market, maybe charge or can be put a tariff that where they charge. So in addition to that 5 euros, they have to cost 2 euros more. So in the market will be 7 euros. So making more complicated to compete that orange with the products that are in the European market. So it's a total protected system, which again is in contradiction with the whole point of the World Trade Organization, which is saying and putting pressure on low-income countries to liberalize and liberalize and liberalize. But when it comes to agriculture, this has been enormous protective policy. This makes that, for instance, this is just to show that how low-income countries are losing in terms, due to these trade policies, are losing $23,000 million every year. So it's a huge amount of money that low-income countries cannot be benefited from because of these, mostly these two main policies, this about the tariff barriers and the subsidies that the CAP is giving, or the agriculture policies are given. This creates these kind of bizarre situations where, for instance, dairy products are moving from Europe to Jamaica, and therefore destroying the whole local production. Or sugar, yeah, we have sugar in Europe too. We have sugar producer, and the European Union, because of these subsidies, is putting the sugar to much lower prices in South Africa that the one that the farmers in South Africa have. And this has happened as well in Mexico with the corn. I mean, Mexico is the origin of the corn is Mexico, and then US put corn in Mexico, which is much cheaper than the corn produced nationally. And they can do that because of the subsidies that are happening in the US. And this obviously has, you can imagine, has consequences for the local or national production, where thousands of millions of producers somehow are living out of the market because of this. They cannot compete with the European or the products from the rich countries because of this kind of support that they receive. So there are different concerns that you can, I have tried to illustrate with the World Trade Organization. One is that definitely right now, despite any other messages that they might want to say, and they say, okay, this is on the long term, this is good for public health. The profit interests right now are before the health of the populations. So that means that there is this kind of free flow trade. They are pushing and pressing governments that the trade is first and the rest of the policies are coming later. This mechanism, though, this kind of court that they have in order to press governments about the different how to achieve this the trade agreement is quite, I would say, quite scary, because somehow violates the capacity that the governments, the sovereignty of the governments to decide what kind of policies should we implement. And not only about public health policies, but any policy in general. And because public health, the health of the population, is somehow taken as a second priority, this is a big concern for WTO. This is somehow illustrate well, the discussions that are taken in, or will represent what kind of WTO probably meeting. So what to do? And that's not so clear. There are people that says, okay, we want to, on one hand, press WTO for reforms. So there is a space that and the WTO should be reformed, because it's the only platform that exists today worldwide where low-income countries might organize and might have a word to say. And they could press governments in different ways in order to change the way they behave. That's one kind of movement that thinks in that way. That the other one is that people said, okay, what we should do is to keep as it is now, but if we are able to organize, and the idea will be that WTO, we somehow keep WTO as it is now without giving more power. And in that sense, we avoid to strengthen WTO by leaving it as it is now. This is obviously a bit tricky because countries within WTO can still, under certain agreements, do different or go farther than the WTO says. So it might require, it will not be so effective, I would think. One alternative could be how well the low-income countries are able to organize, and for some things have been quite strong. For instance, in the case of agriculture, many of the, especially particularly in the last years, low-income countries have been able to organize in different networks and put pressure into the high-income countries in order to liberalize more and to not to be so strict in certain tariffs or subsidies that they have. But but this is still very difficult to maneuver for many countries. In case you are interested, the Lancet produced in 2009. Since 2009, there has been some articles, but not some kind of a coherent block of articles. And then these are written in I think, accessible way as well. In a series of that they produce about trade and health. So I put 2 of the articles that I think would be interesting in case somebody is interested. But I leave it here and see if there are some discussion.
Thank you so much, Miguel. And for you who listen, on the Zoom link, there's a chat box. So please, if you have any questions, write them there. And if there will be any questions later on, I will also leave an email link at the end of the presentation, so you can send them there. Yes, if you have any questions, please write them in the chat box now. And I have just one general question to start, Miguel, because we asked you to focus in the topic of determinants of health, and then this topic came up from your side directly. Why do you focus on this specific topic, or why do you think it's important in the area of public health?
Well, there are several reasons. One is that because it's not known so much, and because it seems to be quite far from, I mean, we are not here to know about how trade works, but we are here to, I mean, if you are doing clinical work, okay, to treat your patients, or we are here to prevent diseases or to protect or to promote health and so on. So it seems that trade is quite far away. That's one aspect. And the one is because this is a real global determinant, because sometimes we talk about determinants like housing or employment, which can definitely have global as well implications, but could be related more to national policies or national how politics are done in each one of the countries. But this one somehow oversees all this and has implications for many other determinants that could be more like at the lower level to some extent. So this is one of the I would think one of the biggest in terms of the global perspective or the global impact, but as well is because somehow it violates or is against one of the key things that we think that are the basis for how we create our societies, which is democracy and the sovereignty of our countries and the freedom of our countries that has been elected democratically in order to establish a series of policies that we think will benefit the citizens. And suddenly come this kind of, most of the times, multinational companies and are able to say to the governments, no, don't do that or do this because this is going to benefit us. So I think that's the way. That's why it's so scary, the whole thing about trade agreements.
Thank you. Yes, I think, for at least for my sake, it was great that you chose this specific topic, because from the side where we study medicine, it's very rare that it comes up at all. Do you think that it's in the structure, or is it also based on a lack of interest, or both? What have you met when you've been working?
It's difficult, but well, on one hand, it's difficult to say. Partly, I think, is because traditions as well. That this is, as I said, not. It's a bit far away. We might think that it's a bit far away of our field. So in that sense, it's not taught. We think that it's very complicated, and then we think, okay, so that's why there are so few somehow people interested or expert that somehow have knowledge about health and knowledge about trade. But has a lot of implications for how food is distributed, what kind of food is distributed, and that has connections with obesity, and that has obviously connections with many other health outcomes. This has implications for the healthcare services and how healthcare services are organized, and why countries like many countries in many low-income countries have so privatized their service, and the governments cannot do anything about that, has the explanation in this kind of agreements.
Another thing that came to mind with the example of beef meat, for example, treated with hormones, was from the One Health perspective, for example, antibiotic resistance. And like, would that be also such a case that if you would see like long-term effects of an increased antibiotic resistance due to import of animal products, would that be hard to target with the current trade agreements?
Definitely, they will be very hard, because they are very, on one hand, they understand, because in that particular agreement, they understand evidence in a particular way. And for them, evidence is a very like a judicial term, very juridic. It's not related to my legal term. It's not so much related to how we in the medical field might understand what is evidence and what is shown evidence, and how we should be somehow adopt a kind of precautionary attitude regarding that, because in case this could help or affect the health, we might not do it, and things like that. This doesn't play any role in WTO. In fact, maybe there are more cases, but I mean, I know only one case that went to trial and won, and the public health won, and this is the case of asbestos, for instance, where in asbestos, with this very well-known carcinogen, and there are, I don't know, hundreds of studies showing evidence that this, because of occupational reasons or other reasons, but there are hundreds of studies showing evidence that this can lead to not only to lung cancer, but the different types of cancer. Well, that's so it took several years for the French government to show that they didn't want to have or to import asbestos from Canada. So the companies from Canada were sued the French government in order to continue the import of Canadian asbestos. And that, so with hundreds of studies that showing that evidence, at the end, and after several years of negotiations, at the end, the court decided that, okay, the public health aspect should prevail here. But that's the only case to be honest, I know. I mean, and there has been hundreds of these cases where health has been argued, but still WTO has decided that trade is first and then health is second.
Yeah, I was thinking about the phrasing that you mentioned before, this, if there are unnecessary obstacles, and the difficulty in defining if they are unnecessary or not.
Yeah.
Another aspect one could mention is, of course, climate change. And you were mentioning it briefly before, but also these long-term aspects on public health, which might be difficult to tackle or to see. Or do you see a change coming there now with, for example, the reports from the Lancet and the Commission on Climate Change and Health, or?
I don't know. I would think I'm a bit pessimistic person, but so I would think no, I don't see very much changes, unfortunately. There might be some successes here or there, but in general, still, yeah, our governments are under the orders of the World Trade Organization, and they have, I mean, it just in a few years a system has been created that that makes that the governments are not able to decide freely about certain policies, because they have all the time this threat that maybe will come somebody that will put us in a trial.
I see. Well, then even more important for us to know more about these agreements. And you gave us some examples of readings here for those who are interested. Do you have any other suggestions for people who might be interested in this topic? How to get engaged, or is there anything that you should focus on or study?
I think, yeah, of course, well, I mean, there are different things. One is to do research about this. It's possible to try to see how these different agreements might affect population's health, and how might affect different social determinants that could affect health. It's very complicated, but it's not impossible. And there are different frameworks and already different studies that somehow try to capture these kind of situations. So research is one area that could be explored. The other one could be, get in touch with networks that somehow in the field of health, but that somehow think that this is not the right way to go. Internationally, maybe I now comes to my mind one that is called the People's Health Movement. So maybe it could be, and because they have a section that specifically works, a group of people that works with the issue of World Trade Organization and trade agreements. And this is a very committed group. They publish as well, I think it's every 2 years, they try to publish a report that is called Global Health Watch. And then always they have 1 or 2 chapters dedicated to the issue of trade and the consequences for health. So that could be another, I mean, two good, I mean, at least more easy, I would think, to get in touch with the People's Health Movement and how they think and the reports, and to be aware of these consequences than research, but the research is possible too, definitely.
Thank you for those suggestions. Okay, so I cannot see any questions here in the chat. I had one question through email, and it was more focusing on if this session will be available later on. And we have recorded this, so it will be available on our YouTube channel, on SLS KUF, but also on the website.
And if you want the presentation,
perfect.
I can send you.
Thank you, Miguel. That's really nice of you. Do you have any other last words that you would like to add now? Something that we haven't asked? Or?
No, I think it has been good initiative. So good luck with the rest of the week.
Thank you so much, Miguel. And we're very happy to have you as a speaker and to bring in this quite different aspect from the other lectures this week, or these 2 weeks that we have this year of global public health. Then I will share my screen again just to show the last slides with information. Let's see if I can do this. And let's see if it can change also. There we go. And I was assigned to be technically in charge for this session earlier today. So I think it's quite exciting myself to see how it works. But I'm trying to get you a slide with email addresses just so that you can email us if you have any questions. But I'll try to share this one instead. see here. Maybe it does not want to. There. Okay, so yeah, once again, thank you, Miguel. And if you have more questions, you can send them to either globalhalsa@slskuf.se, sorry, my Swinglish here, or prevention@slskuf.se. And you can also read more on our website, where you can become a member for 50 kronor a year as a student, or 350 kronor a year as a junior doctor. And don't forget to join the rest of the program this week. I think next session is tomorrow on children's health and climate change. And then the next session in English will be later on. I think it's on Thursday. But do check the overall Facebook program for more information. And also we have our annual meeting on the 21st and 22nd of November, where you're welcome to join. We will have some online workshops, and also we will have a ceremony online this year where we give out our awards. So check out this Facebook event if you're interested to know more. And with that, thank you to all of you who have been participating today. And yeah, please send us an email if you have more questions. And thank you once again, Miguel.
Yeah, thanks to you.
Thank you.
Yeah,
Bye.
see you. Bye.
See you.